Hello and welcome to another episode of M.I.N.O.R Talk. I'm Yue, your host for today. In today's episode, we're going to take a look at some of the prominent issues in the field of public health, along with Dr. Khor Swee Kheng. He's the co-founder and coordinator of the Malaysian Health Coalition and also the Chief Executive Officer of Angsana Health. Welcome, Dr. Khor. Would you like to give a brief introduction about yourself?
Hello, Yue, and hello to all the readers and listeners as well. I'm from Malaysia, from Taipei, and since graduating as a doctor from the National University or UKM, I've had three careers. My first career is as a medical doctor for 5 years, and my second career is in pharma for 8 years, and in my third career so far, it's been about 4 years working in global health and now healthcare startups through Angsana Health. I am trained in medicine, in public health, and in public policy, and I've lived and worked and studied in about 12 countries in the world, including covering 90 countries professionally. It's a pleasure to be here, Yue. Over to you.
Okay, so we'll start off with the first question. So, Dr. Khor, what is public health and why is it significant in this day and age?
This is a great question. Maybe we can spin the question, Yue, to ask what is not public health? Because everything is public health. Let's tell the history of public health very briefly. The first public health specialist, right, is not a medical doctor. The first public health specialist is the water engineer. Because when we had diseases like cholera and typhoid, it took water engineering, sewage, sanitation, plumbing to improve the water systems in cities and countries around the world. And this wasn't so long ago, about 150 years ago, that the water engineers became the first public health people. The second group of public health people came around just after Second World War, when we had a lot of statisticians and mathematicians. Before the Second World War, we had a lot of microbiologists. So if you trace the evolution, it's a water engineer, then the microbiologist, then the statistician, and these days, the very important people who are doing public health are actually the economists. If you project 50 years into the future, the people who will be doing a lot of work for public health will be social scientists, because public health is not just about diseases as well as control of infectious diseases like COVID or dengue or malaria anymore, because we need the social determinants of health when we're looking at public health. So what are the social determinants of health? There are things like, what are the labor rights of the people who are working in factories and farms and fields and even in aviation, all sectors? Because if you can't protect workers in terms of sick leave, maternity leave, social health insurance or health insurance, and also occupational safety, and then workplace mental health and workplace well-being, then you're not really addressing public health. So that's one example of social determinants of health, the conditions in which you work. A second example of the social determinants of health are the conditions in which you live. Meaning, let's just say somebody's got asthma. You can build all the hospitals in the world and all the emergency departments and all the ambulances in the world, but you cannot save the person with asthma if there is a factory next door that pollutes the air. That's a second example of the social determinants of health, the conditions in which you work and live. The third example and final example of the social determinants of health would be what we call the economic determinants. For example, big tobacco every year spends millions of dollars in lobbying and advertising. Another example, let's call it fast food, right? Any number of fast food outlets like McDonald's, Burger King, Wendy's, and so on. All that contributes to obesity and non-communicable diseases. And McDonald's is the world's largest restaurant chain. So those are examples of how the social determinants of health are all very important in determining what is public health. So your question is, what is public health? And my answer went from history, from water engineering all the way to the social determinants today. And we can see why public health is so important and cannot only be left to the medical doctor working in a hospital, because we need everybody in charge of public health. Thank you, Yue. Over to you.
Wow, that's a very interesting and comprehensive answer. Thank you for your insight. So we'll move on to our second question. Citing what our ex-health minister's keynote speech regarding the health white paper at the Health Policy Summit 2022 during August this year, the health model today still premised on a predominantly curative lines, responding after the fact to illness, disease, and infirmity. we do not sufficiently anticipate the future. How should this transition from the sick care-oriented system to the holistic healthcare and wellness-dominant system best be carried out?
Another great question, Yue. This is a 12 trillion US dollar question. 12 trillion is the number that we need to look at, because 12 trillion US dollars is the size of the healthcare economy around the world. In other words, the whole world every year spends $12 trillion on healthcare. 95 or maybe even 98% of that is curative. These numbers are very difficult to look at, but it's safe to say that in most countries, a lot of the spending is on curative care. I know Malaysia's number. Malaysia's number is 97% on curative care. And so is the OECD, also at 97, 96, 97% on curative care. The point is that of the $12 trillion spent on healthcare in the world, 95 to 98% of it will be spent on curative care. There's a whole speech about how preventive care is important. I don't want to give that speech because we're tired of hearing that speech. So your question is, how do we get there? I will say two things. Number one, we need to have the political will to make those changes, and the political will to make those changes, meaning to transfer some money, more money from curative to preventive, but not to transfer overnight, but to transfer gradually over a period of 5, 10, 15, or 20 years, so that curative services are also protected while we increase the capacity of preventive services to do better and to spend the money properly. In other words, preventive care is important. We need political will, and we need to transfer the money from curative to preventive over a gradual process measured in 10 to 20 years, not immediately. Why? Because if today you're used to spending 1 million ringgit a year on preventive care, if tomorrow I give you 500 million ringgit on preventive care, you don't know how to spend the money. And secondly, there could be corruption, wastage, fraud, and abuse, and we need to eliminate all that. So political will is important to shift from curative to preventive and to shift that gradually. The second thing about political will is to remember the number of $12 trillion. If you shift money from $12 trillion from curative to preventive, people are going to be upset with you. Why? Because they're already profiting a lot from curative care. So companies that are, and agencies, institutions, and so on, they're already profiting for so many years from curative care. If you take away their money, they will be upset and they'll fight back. Therefore, this must be done gradually without threatening them or making them feel threatened. That's one important example, which is to move from curative to preventive is to have political will. Obviously, it's not easy to have political will. The second thing about moving from curative to preventive is to look at behavioral sciences and behavioral psychology. Meaning, it is very difficult to change human behavior. It is human nature to not care about your health until the very last minute. It's a very standard problem. To fix that problem is you require not only financial incentives, but psychological tools to help people live better and make better choices and even seek for preventive care. So it's not enough that you put money into preventive care and have the political will for preventive care. You must also look at how people access preventive care and use behavioral psychology and behavioral science and behavioral insights in order to encourage people to access preventive services. These are the two main ways about how we can move from curative to preventive. You note that I spent 0 seconds talking about why is preventive important. It's, the time for talking is over. The time for action is now. Over to you, Yue.
We all definitely know that prevention is better than cure, but it's shocking to hear that we are not focusing enough on preventive care through the data you highlighted just now. Fingers crossed that more stakeholders of the public health system will realize this and carry out reforms on this issue, as everyone should acknowledge that the preventive care model is as important as the sick care-oriented system. Another topic many people would come across would be that the Malaysian healthcare system is dichotomous, with a primarily tax-funded public sector on one hand and fee-for-service private sector providers on the other. Many experts had suggested through various studies since the mid-1980s that some form of prepaid payment like social health insurance, namely a national health financing scheme, might be more suitable in today's public health landscape. This requires a major shift from tax-based financing to a contributory system, What is your take on how the public health system funding model should be structured?
Another great question. So, if you recall, the first question that you asked me is about what is public health, right? The traditional public health physician is very good at infectious disease control. The curriculum for teaching or training public health physicians are very geared towards disease control, dengue, diabetes, COVID, and that's all great. Now, your question to me is about funding. And traditional public health schools don't really train funding and financing. Therefore, we need to rely on health economists and social scientists to help us design a public health system funding model. You asked me about how it should be structured. Instead of answering this question, let me give guiding principles, okay, for how it should be structured. If we have good guiding principles, we will know how to structure it. The first guiding principle is that we must have multiple sources of funding. Now, most of the time when we talk about funding, we have to talk about sources of funds and users of funds. The sources and users of funds. And naturally, it's just logical for us to have diversified sources of funding. In Malaysia today, it's 50, 40, 10. 50% of funding for healthcare in Malaysia comes from the government. Where? Taxation. 40% of the funding from healthcare in Malaysia comes from out of pocket, meaning we pay from our own savings and bank accounts. 10% of today's health funding in Malaysia comes from insurance, meaning we buy from Great Eastern, AIA, Prudential, or the major insurance companies in Malaysia. So it's 50, 40, 10. Well, in reality, it's something like 53, 37, and 9, or something like that, right? But that's easy to remember. Let's make it 50, 40, 10. Now, this is diversified, but can we add a fourth component? Can we add a fifth? Can we add a sixth? And 4, 5, 6 could look like number 4 could be social health insurance. Number 5 could be a contributory scheme from that takes out from your salaries and wages on a monthly basis. And number 6, maybe even Islamic financing like zakat and wakaf, using the Islamic bonds and so on. And I'm not an Islamic scholar, but it's a very large fund in Malaysia that we can reliably access as well. So then instead of 3 sources, then we have 6 sources. Now, that's one guiding principle. Have a proper diversified group of, say, sources of funds. The second guiding principle would be, obviously, not to rely on 1 out of the 6, or 1 out of 5, or 1 out of 4. If you have 4 sources of funding, but 1 source of funding is 90% of it, then you're basically having just 1 source of funding. So it needs to be appropriate, like probably even smoothened out and roughly equal to each other. Now, obviously, we'll never be able to achieve rough equal. 50, 40, 10, my personal opinion, is probably not satisfactory. The 40% out of pocket needs to be cut to 20%. And the WHO, the World Health Organization, does not specify how many percent of your GDP you should allocate to healthcare. But they do specify that a maximum of 20% out of pocket is acceptable. So from 50, 40, 10, we probably need to get it down to, I don't know, maybe around 40, 40, 20, or around there. Therefore, we will arrive at a third principle, which is we're not utilizing our insurance enough. Let me recap right now, right? Firstly, we must have diverse sources of funding. Secondly, we must have a roughly equal set of sources rather than being disproportionately reliant on one source. And thirdly, we're not using insurance enough. And when I say insurance, it does not need to be private insurance. In Japan and in Germany, 2 very rich countries with quite significant numbers of the population who are older, there are no public hospitals. All hospitals are private. But in Japan and Germany, all private hospitals are non-profit making, meaning they are not owned for profit, they're not listed on the stock exchange, they are operated as a private hospital because they have to make profit, but the profit is kept inside the hospital and reinvested in the community. A similar model can be seen in insurance, that there are many countries that offer insurance, but non-profit insurance. Or if there's profit, then it goes into the insurance or to the members, but not to shareholders. So this is a sea change, right? Because you can have a private hospital that is non-profit. You can have a private insurance that is also non-profit. Let me end with the example of what other countries in Southeast Asia have done. And Malaysia can take some examples from them. Thailand started off a national health insurance scheme in Thailand in 1999. Today, they've got 3 contributory schemes in Thailand. Contributory meaning they take 1% or 2% or 3% of your salary on a monthly basis, like EPF, but it's only for your health or your family's health. The Philippines also, since 1999, the Philippines Health Insurance Corporation, and Indonesia, operating the world's largest government insurance program that's operated on a non-profit basis, bigger than America, bigger than any other country, because Indonesia has 270 million people. Indonesia since 2014 through Jaminan Kesihatan Nasional. So Malaysia can also follow some of these countries like Thailand, Philippines, and Indonesia right next door to us, roughly the same income level. So we can't say that health insurance is a rich country thing. It can also be a middle income country thing. Let me pause here, and that's how I think that the public health system and the funding models of the public health system could look like. Over to you.
Yeah, I definitely agree with you on the notion that diversified sources of fundings can help secure the operations of our public health system, and it's really interesting and inspiring to hear about private medical institutions overseas reinvesting their profits back to fund healthcare. So moving on to the next question. From what I know, you are the Chief Executive Officer, CEO of Angsana Health. The core value of this startup is to provide patient-centric and integrated solutions for primary healthcare in Malaysia and Southeast Asia. Could you kindly elaborate on what is primary healthcare and its prominence, along with what inspired you to start this kind of initiative?
Great question, sir. And to end our little interview tonight, Yue, thank you so much for the interview. So your question is, what is primary health? And secondly, what inspired me to start up Angsana Health together with 40 colleagues right now. So we've got 40 people in Angsana, so I'm very proud of them, and they're just awesome people. So there are many different dictionary definitions of primary healthcare. We can all read that by ourselves. Here is my definition of primary healthcare. Everything outside the hospital is considered primary healthcare. Now, there's obviously a technical definition of primary, secondary, tertiary, and even quaternary healthcare. Let me set that aside on academic terms, right? But everything outside the hospital can be considered primary healthcare already. Now, primary healthcare is traditionally considered the clinic, which is true. And Malaysia's health system is built on primary care because we didn't have hospitals, good hospitals or big hospitals scattered around the country until maybe the 1970s or so. So between 1930s or so, all the way to 1970s and 80s, healthcare was just delivered through primary care, meaning clinics. But today, clinics alone are not enough. We need community care because people might not come to clinics to receive healthcare. Therefore, they need healthcare at home, so home-based care. They need care in the community, therefore community-based care. They need care in their pockets through their smartphones, therefore they need digital healthcare. And these are three examples of how primary care has gone outside of the physical clinic. So the traditional conception of primary healthcare is the clinic, but it's gone on so far, right, that it's become community care, digital care, home-based care, and all the different cares outside the clinic, all of which are very important in primary healthcare. So in short, what is primary healthcare? It can be easily summarized to be everything outside the hospital. Then your second part of the question is what inspired me to start Angsana Health. We started it about 1 year ago, so it's January 2022 that we started Angsana Health. The idea for Angsana Health is to eventually build a primary healthcare system in a few Southeast Asian countries, not just in Malaysia. So we hope to build a primary healthcare system for 10 million people in 5 countries in Southeast Asia in the next 10 years. Why do we want to do so? Firstly, primary care is very important. There's a whole speech about why primary care is important. It's accessible. It brings more equitable healthcare access. It lowers costs. You build good relationships with your primary care provider. Whole speech about why primary care is important. I don't want to give you that speech. Instead, I'll say that from a system perspective, the investments in hospitals in Southeast Asia have been very high since 1990s. But investments in primary healthcare have been prioritized or underinvested or underdeveloped since the 1990s. So we think that there is a need for us to go there. There is a need, but also a commercial opportunity for us to go there as well. So that's the second reason. And thirdly, we want to use Angsana as a vehicle to do public service, meaning how can we deliver public service, but through the private sector route? And that's the main, one of the 3 main reasons for us to start Angsana. Firstly, primary care is important. Secondly, the renaissance of primary care is really upon us after decades of underinvestment. And then thirdly, we think that we want to use Angsana as a way to deliver public service. Those are the reasons.
First of all, it's really inspiring to hear about your thought process with you and your team in starting this Angsana healthcare startup. I really also like how you explain the term primary healthcare, in layman terms, which is easier to understand. So moving on to our last question for today. It is evident that there exists a stereotype that medical students upon graduation should become clinical doctors. As a medical professional, you have vast experiences in both clinical and non-clinical settings. Could you share with us your transition from having a job as a doctor from the start of your medical career to securing fellowships from notable international organizations? What advice would you give to a medical student who is undecided on whether to pursue a non-medical career or not?
Thank you. It's a difficult question to answer because there's not enough time. But two questions. Describe my transition and what advice would I give? To describe a transition is a very long story, and I guess if you're interested, you can read about this on the internet about the different career. I will say a few things. See, when I was young, I didn't know what I want, and it took me a long time for me to have the vocabulary to explain what I want, and you use words to accurately describe what I want. So I will say that transition needed time. Secondly, the transition needed luck. Thirdly, the transition made me feel very grateful. It needed luck because luck and fate and timing are things that we cannot control. I worked hard and I think I made good choices, and I tried to be a good person to everybody that I meet. Nonetheless, right, there are so many things that I cannot control. Having good people giving me opportunities, having people trust me, having mentors who supported me and guided me. All these things are things that I was very lucky to receive. So luck and fate and timing are very important to me in those transitions from one career to another and one country to another. And thirdly and finally, it gives me a lot of feelings of gratitude that I feel very grateful. And that feelings of gratitude gives me a sense of a duty, that I feel a sense of duty for me to not waste my good luck. So those are my thoughts about the transition, about when I moved and what I moved to and so on. It's a matter of public record, and I prefer to spend too much time on that. In terms of advice, it's difficult to give generic advice to everyone because different people need to hear different things at different times in their lives. But here's some generic advice anyway. The first generic advice would be, find the truth that is true for you. Meaning, if you ask for advice from people, even let's assume that they all have good intentions, okay? And we know that not everybody has got good intentions, even if you ask them for advice. The point being that when you ask advice, and you ask advice from a small group of people that you really trust, and then use those as data points to make decisions for yourselves. In other words, right, advice is important, and many people give me very, very, very good advice, and I'm very grateful to them. However, you ask the same question to 10 people, you get 50 different answers. And it's not always easy for you to discern the signal from the noise. In other words, find the truth that is true for yourself. Number two, when you're asking questions for advice, don't ask for what to do, but ask for thinking processes of how to achieve the decision. In other words, don't ask for the decision, but ask how to make the decision. If you ask for a decision, should I do A or do B? People will tell you should do A or do B. If you ask the question, how do I decide between A and B? That's a different question, and you get a very different answer from them. Thirdly and finally, maybe my advice, since you asked me my advice, right? My first advice is find the truth that is true for yourself, meaning use all the pieces of advice as a data point, but not the sole course of action. Number two, don't ask for decisions, but ask for frameworks and thinking processes to make decisions. You see, I'm not giving you any advice, Yue, my friends, right? I'm telling you how to give that advice because I don't like giving advice. It has to be really tailored. Now, finally, though, here's a piece of unsolicited advice. I am not in formal clinical medicine right now. I train as a physician. I qualified as a physician. I can be a physician, but I left practice about 10, 12 years ago. The point being that I'm doing totally different things. Do I miss clinical practice? I do. Did I find that clinical practice was not a good use of my time? Why? You're doing other things right now, so why go through housemanship and make it so difficult for yourself and so on and so forth? Yeah, I get sometimes asked this question. But if I may, here's a piece of unsolicited advice, is to say that I might recommend, I'll use the word recommend, to medical students, okay? This is not to junior doctors. The advice is only for medical students. You studied medicine, go be a doctor. Go be a doctor and figure it out, and then you decide whether or not you want to leave. That few years, if 1, 2, 3, 4, good number of years that you spend as a medical doctor gives you life experience, ability to make decisions under pressure, time prioritization and prioritization skills, including the ability to make decisions under a lot of pressure. It gives you credibility. And finally, it gives you the comfort of knowing that you have become a doctor, you have trained to be a doctor, and you have practiced as a doctor. It is a beautiful feeling. So if you're a medical student, not junior doctors, but if you're a medical student, I recommend to you to have even if it's a short period of time, be a doctor. You all will live till 100 years old. If you graduate at 25 years old, you will work till you're 75 years old. That is a 50-year career. 5 years becoming a doctor in the beginning of that career, you're not wasting anything. Thank you, Yue. Over to you.
Hearing what you have shared just now, you tried very hard to do your best, be it whether you were in the clinical or non-clinical phases of your career. I really like your core values. So thank you for your time today, Dr. Khor. So that wraps up today's episode. My heartfelt gratitude to Dr. Khor for sharing insightful knowledge and inspiring experiences on the topic of public health. I believe all viewers of the show will be enlightened by the information shared just now. Thank you once again, Dr. Khor. It's an honor to have you here today.